Welcome to the deep dive. Today we're tackling a really important topic for us interventional radiologists. Transjugular Intrahepatic Portosystemic Shunt, or TPS complications. Now, TPS is incredibly effective for portal hypertension, we know that, but it's technically demanding.
It absolutely is.
And direct procedure-related morbidity rates can climb as high as 20%.
Which is significant. So today, our goal is really to provide a clear roadmap for you how to prevent and manage these issues right from the start, pre-procedure, all the way through to long-term follow-up.
Exactly. Let's start right at the beginning then. Minimizing complications, that really has to begin before the patient even gets near the angio suite, doesn't it? With that pre-procedural workup.
Absolutely. Meticulous pre-procedural evaluation is key. We're talking rigorous patient selection and careful risk stratification.
Okay, so let's break that down. When you're evaluating a patient, what are the absolute must-dos? What flags tell you, hang on, high risk here, or maybe even TPS isn't the right call?
Great question. First off, hepatic function. It's critical. Your MELI score is a good guidepost. Ideally, you want it below 18.
Below 18, okay.
Yeah, go above 18, or if the Child-Pugh score is over 10, the prognosis, well, it gets poor. There's a much higher risk of post-TPS liver failure.
And it's not just the liver, right?
Not at all. Cardiac assessment is equally vital. You absolutely need a pre-TPS echo.
What are you looking for specifically on the echo?
Things like elevated right atrium size, LV dimensions, and crucially, an estimated peak pulmonary artery systolic pressure, PASP, above 31 millimeter Hg. That predicts post-TPS heart failure.
So PASP over 31 is a major warning sign.
A major one. And if there's pre-existing right ventricular failure, TPS is generally contraindicated.
Makes sense. What else in terms of patient factors needs optimization beforehand?
Well, you need to get their coagulation profile and platelet count as close to normal as possible. Mitigates bleeding risk, obviously.
Right.
Also check thyroid function. You want the euthyroid to help prevent hyperammonemia and that dreaded hepatic encephalopathy, HE.
And if they already have HE,
that requires really thorough patient counseling. Discuss the risks. If they've got poor social support or multiple risk factors, you might even lean towards non-TPS options.
Okay. What about ascites, refractory ascites specifically?
That independently adds risk for liver failure post-TPS. And critically, you need to screen for abdominal or inguinal hernias.
Because the rapid decompression can cause incarceration.
Exactly. It's a known issue.
Yeah.
And always remember, emergent procedures just carry higher mortality. It's the reality.
Good points. Now, how does imaging fit into this prevention strategy?
Imaging is vital. Comprehensive pre-procedural imaging, CT, MRI, ultrasound with Euler Doppler, it gives you that detailed anatomical map.
To find the optimal puncture sites.
Precisely. Optimal hepatic vein, portal vein puncture sites. Plus you can spot things like portal venous thrombosis or even tumors that might be in the planned TPS path.
And contrast.
Using carbon dioxide for wedge sonography, it's definitely a safer contrast agent in this setting. Oh, and prophylactic antibiotics. Yeah. Generally recommended, like a single pre-procedure IV dose.
Okay, so we've done meticulous prep. But we know complications can still happen during the procedure. What are the immediate risks we're watching for once we start?
Right. Even with the best planning, things can go wrong. Vascular access itself is the first potential hurdle.
Like carotid artery injury?
Yes, during IJ access. Real-time sonographic or fluoroscopic guidance is your best defense there. Also, right atrial perforation. If you anticipate prolonged access, maybe exchange that long 10 French sheath for a shorter one.
And then the real technical challenge, finding and accessing the portal vein. That feels like where a lot can happen.
It is. Liver capsule transgression isn't uncommon, maybe up to a third of cases, usually minor, but intraperitoneal hemorrhage occurs in 1-2%.
Any particular structures at risk?
The gallbladder is actually the most frequently punctured organ, surprisingly. If you suspect hemorrhage, you need immediate imaging, cone beam CT, ultrasound, then angiography with embolization if needed. A successful TPS placement can sometimes tamponade portovenous injuries, though.
What about more severe vascular injuries?
Portal vein perforation is rare, maybe 0.5%, but potentially fatal. Look for sudden tachycardia, massive contrast extravasation.
And the management?
Immediate. Rapidly place and inflate an angioplasty balloon, then deploy a covered stent right away to seal it. Hepatic artery injury is another serious one, 1 bitter 6% incidence.
What if you inadvertently enter the artery?
Slowly withdraw the catheter, or sheath, and embolize the tract. Critically, avoid embolizing the artery itself. Biliary duct injury is also possible, though rare, less than 5%. Can cause fever, sepsis, shunt stenosis later on.
How do you manage that, biliary injury?
Often requires stent graft placement across the fistula, maybe percutaneous drainage, or even an endoscopic biliary stent.
Okay, moving on to the stent itself. What complications relate specifically to the device?
Proper positioning of the covered stent is crucial, usually 2 to 4 centimeters into the portal vein, extending back to the hepatocaval junction.
And migration.
It's rare, but it's a big problem if it happens. Caudal migration, downwards, is tough to retrieve. There's an involute technique described for that. Cephalid migration towards the heart can cause arrhythmias or perforation. Again, difficult retrieval, might need snares or balloons.
So rule number 1 is keep that wire access.
Absolutely maintain wire access after deployment until you're sure it's stable. Also, there's a specific issue with the Viador device, tabletop TPS mal-deployment, where it deploys prematurely. Thankfully, there are methods to reconstrain and redeploy it.
Good to know. And coiling varices.
Use microcatheters and microcoils. Prevents vessel trauma during embolization.
All right, procedure's done, stent is in. What are the key early post-procedure complications we need to jump on?
The immediate post-op period is definitely critical. Acute hepatic encephalopathy, HE, is quite common. Rates vary, maybe 5-35%. Some studies even say up to 50%.
What predicts it?
History of pre-TIP-PS is a big one. Also advanced liver dysfunction, child PUC, MELD over 18, and sometimes a very low post-TIP-PS pressure gradient, like under 5 mm Hg.
And management for HE?
Usually medical. Lactulose, maybe a protein-restricted diet initially, rifaximin. For severe or refractory cases, you might consider shunt reduction. That's often preferred because it's reversible, unlike complete occlusion.
What about the really scary stuff, like acute liver failure?
It's rare, thankfully, but severe. Presence with climbing LFTs, coagulopathy, worsening encephalopathy.
Causes.
Often related to decreased portal perfusion after the shunt, or maybe stent compression on vessels. Management might involve urgent TIPS occlusion with coils or plugs. Unfortunately, liver transplant might be the only real option sometimes.
And acute shunt problems, occlusion.
Much less common now with PTFE-covered stents, usually less than 5%. Structural issues from suboptimal positioning are probably more common now than frank thrombosis.
How do you handle those?
Angioplasty, maybe choromolysis or mechanical thrombectomy if there's clot. If the configuration is just suboptimal, you might need to extend it with another stent or even create a parallel TPS.
What about the heart? Hemodynamic changes.
Right. TPS definitely increases preload and can exacerbate that hyperdynamic state you see in cirrhosis. It can lead to cardiac decompensation. Management is primarily medical diuretics, oxygen, but prevention through that careful pre-procedure cardiac assessment we talked about is key.
Any other early issues?
Hemolytic anemia is a rare one, usually seen more with bare metal stents than stent grafts. It's often self-limited, resolving by about 12 weeks as the stent endothelializes.
Okay, so that covers the immediate aftermath. Looking further out, the late post-procedure period, what issues require long-term vigilance?
Ongoing surveillance is absolutely essential. The main thing is recurrent symptoms of portal hypertension, which usually signals shunt dysfunction.
How common is dysfunction now with covered stents?
Patency is much better. With Viator, for example, primary patency can be up to 76% at 2 years. But if symptoms recur or ultrasound suggests a problem, you need TPS angiography with pressure measurements.
And if you confirm dysfunction?
Usually balloon and angioplasty first. If that doesn't work, relining the tips with a new covered stent is often effective. For complete occlusion, you might need thrombolysis, thrombectomy, angioplasty, or potentially creating a new parallel tip PCs.
You mentioned hernias earlier in the context of ascites. Can they become a problem later on?
Yes, definitely. Hernia incarceration risk is increased, maybe up to 25% in patients who had significant ascites. Presentation is often delayed, median around 2 months post-tip Ps, and it frequently requires emergent surgery.
What about infection? Tipsitis?
Tipsitis or endotipsitis is rare, maybe 1-10%, but it can be lethal. Mortality is high, around 32%. You suspect it was sustained unexplained bacteremia.
Common bugs.
Things like Enterococcus, Klebsiella, Staph aureus. Management needs aggressive antibiotics. Sometimes removal of the infected device is necessary, and transplant can be an option for refractory cases.
One last point, radiation.
Yes, radiation exposure is a real concern, both for the patient and the operator, given potentially long fluoroscopy times. Prevention is key. Minimize fluor time, use dose reduction tech, collimate tightly, and always use proper personal protective equipment.
So bringing it all together, it seems optimizing TIPS outcomes really demands a comprehensive approach.
It absolutely does. It's synergistic. Rigorous patient selection up front, meticulous technique during the procedure, quick, decisive management if complications arise intra-op, and then diligent, long-term follow-up.
And teamwork.
Definitely. A collaborative, multidisciplinary team makes all the difference in maximizing the benefits of TIPS.
Which leads to a final thought, perhaps, looking ahead.
Yes. What new innovations are on the horizon? Could new device designs or perhaps procedural guidance systems further simplify TIPIOs, reduce those technical challenges, and improve safety, especially for our most complex patients? That's something to consider.